Bismillahirrahmanirrahim. Assalamu alaikum. I'm Dr. Mohammad Waleed Hassan. I'm a registrar cardiology and fellow intervention cardiology from Fouji Foundation Institute of Rawalpindi. I would first like to thank the PMA and Sir Akhtar Bandesha for letting me present my case on such a big form. So can I have the slides? So the topic of the case is there is always a silver lining, or there is always some light at the end of the tunnel. So my case was a 75-year-old lady. She was diabetic, hypertensive, and she had history of mucoepidermoid carcinoma that was treated by radiotherapy since 2019. Her last session of radiotherapy was in January 2022, and she's in remission right now. She had a history of non-escalation MI in December 2022. When she presented, she was vitally stable. Her general physical examination and systemic examination were unremarkable. Her lab investigation revealed her HB of 11.1, and serum creatinine was raised to be 220 micromole per liter. Her ALT was normal. Her hepatic screening was negative. We did an ultrasound KUB, which showed grade 2 renal pericardial disease. Her echocardiogram was done, which showed an ejection fraction of 45% with inferior and inferioseptal hypokinesia. We took a nephrology review, and the nephrologist advised her conservative management and labeled her high risk for CIN. So after pre-hydration with normal saline for a couple of days, her creatinine came down to 140 micromole per liter. She underwent a diagnostic coronary angiogram with a limited dye from the right radial approach. This is a diagnostic angiogram. As you can see, on engagement of the left-sided catheter, there was left main disease, critical left main disease, and there was some also ostial circumflex disease in the caudal views. We took the AP cranial view. This is the AP cranial, which showed ostial circumflex disease, and there is some moderate to severe disease in the mid LAD as well at the junction of at the bifurcation of the diagonal vessel. This is RAO cranial. It also shows some moderate to severe disease in the LAD as well. Here, the LV angio showed fair LV systolic function. The RCA, when engaged, it was totally occluded from the proximal course, and the engagement was a bit difficult. As you can see, there is no support of the guiding catheter, and there was pressure dampening on the engagement as well. There is also cross-filling of the RCA from the Doppler. The surgeon deemed her very high risk, and he advised to keep her on medical treatment and not to proceed with the CABG. So we put her on optimal medical therapy and full dose of anti-anginals, but despite that, she had recurrent symptoms of angina, and she had recurrent admissions with unstable angina. So we proceeded, her CT carotid could not be done because of the history of deranged renal profile. So we proceeded with the MRA carotid to see to confirm for the disease in the carotids. The MRA unfortunately had some discrepancy with the ultrasound Doppler, and it showed some limited study with the normal carotids. So now the patient got again admitted with us just recently with again a non-escalation MI with ongoing chest pain. Her fresh echocardiogram again revealed an EF of 45% with the same inferior and septal wall hypokinesia. Her fresh labs again were normal except for a raised serum creatinine of 130 micromole per liter. So the question was what to do next, as she had already been declined surgery by the surgeon, and she had ongoing chest pain, and she had recurrent admission, and she had daily symptoms of ongoing angina. So after taking a detailed history and after getting a detailed counseling of the family, we decided to proceed with the high-risk angiogram and high-risk angioplasty with the backup of the anesthesia. So we decided to proceed with the carotid angio initially to confirm for the carotid disease and to proceed with further with the high-risk PCI with anesthesia cover. She was well hydrated before the procedure, and we followed all the protocol of CIN that included the high-dose statin, the magnesium sulfate, the soda bicarb. So all were followed. Her serum creatinine before her cath was 110 micromole per liter. So we took her to the cath lab. We took a right femoral approach. As in all cases with the femoral, we usually do ultrasound guided puncture. We take a picture just before the angiogram to make sure that the puncture site is correct. Then we took the left system. As you can see, there is some increase in disease in the left circumflex, and the rest of the disease was as before. So these are the further picture of the left side. Wait, sorry. So this is the last slide shows the engagement of the common carotid artery. This is how we do it. We just put the wire up through the common carotid artery, and then we push the guider up and we engage it. So on the left side, there was slightly moderate disease in the common carotid artery, and on the engagement of the right side, as you can see there, yep, there is a severe to critical disease at the bifurcation, also extended into the internal and external carotid artery. Yeah. Here you can again see on the right side, there is a critical disease at the bifurcation of the right common carotid artery. But she was asymptomatic. She did not have any symptoms of CVA, so we decided to come after it later. So we first decided to go for the RCA, as it was the CTO vessel. We went up front with a high tip wire of, we took the Gaia 3 wire with a micro catheter, and the plan was to puncture it and to go and to do a Cardino. But as you can see, there was no back support of the guiding catheter, and we could not cross the Gaia 3rd into the true lumen. So we took the another catheter, the XB-RCA. You can see this in other views. We took the XB-RCA for extra backup support. It's basically a catheter that's a combination that shows a combination of implants and the right Judkin. So even with that, we could not cross the Gaia downwards. And up till now, the total dye used was 100 ml. So when we could not cross it, we decided to shift to the left side because the patient was still having angina symptoms on the table as well. So we decided to fix the left main to circumflex. So for the left sided, we took the XBL catheter, sorry, and we wired the LED. The run-through wire was parked in the LED, and we took the pilot 200 for crossing the circumflex artery. It was we had some difficulty in crossing the circumflex. We crossed it with the help of a micro catheter, but at the end, the pilot 200 was crossed in the distal circumflex, and it was parked in the distal circumflex. And after parking the micro catheter downward, we exchanged it with the run-through wire, workhorse wire. So we took some more pictures, and then we did the pre-dilation with the 1.15 20 balloon, and then with the 230 balloon. Here some further pictures. Then we decided to put a stent from left main to circumflex. It was the 338 stent, and we tried to cover it in the distal disease. We took a aleocranial view for it, and we then we just stented from left main to circumflex. At this time, there was a lot of pressure dampening. Her pressure came down to almost 30 to 40 millimeter of mercury. So we deflated early, and we let the vessel settle down, and the pressure came back up. So this is the picture after the stent was deployed. You can see there is some haziness at the outflow of the stent. Here. We post-dilated it with a 3-5-20, but then we can see there is some haziness at the outflow of the stent. So we decided to put another stent there. We took a 275-15 and covered the distal lesion. And we post-dilated that with the 3-5-20 that we had already opened up. So this was the final result of the left main to circumflex. Then we decided what to do for the LAD. As here the lesion of the LAD looked to be moderate to severe, so we decided either we go for a FFR or we go upfront with the stenting of left main to LAD. We do a QLOT. At this time, the total dye used was almost 250 to 300 ml. So on account of her derange, but her symptoms had settled right now, and there was no ECG changes. So we decided to do an IVUS run for the apposition of the stent, and then do an FFR for the LAD. This is the IVUS catheter that is going down. I'll show the pictures of the IVUS later. And this is the FFR wire going down the LAD. We did a FFR for the LAD. The FFR for the LAD came up to be 0.8, so it was borderline, so we decided to leave it and look for some symptoms. If she becomes symptomatic, we come back for the reverse QLOT to the LAD. At the end of every femoral case, we take a picture of a bladder to see for any indentation. So these are 2 IVUS runs that we did. These show that there is optimal apposition of the stent. The stent is well apposed to the vessel. Yeah, you can see there is some indentation in between, but the stent is well apposed to the vessel wall. The MLA was calculated. The left main MLA from IVUS was almost 12 millimeters square. This is the second run. It almost shows again the stent was well opposed. So moving on. The patient remained pain-free post-procedure for the next 48 hours. She is still admitted with us and she is pain-free. There was no XX side complication. We have kept on our IV hydration on account of her deranged renal profile. And we have started high-dose statin and all the protocol of CIN. Her latest serum creatinine is 120 micromole per liter. The plan is to keep hydrating her for the next 2-3 days and see if she becomes symptomatic, then we'll come back for the LAD. This is the little interview that we took of the patient with the patient consent post PCI.
Assalamu alaikum, dear masters. This is Dr. Waleed, our intervention fellow. That's Dr. Zoha. Waleed had presented the case yesterday, and this is our dear patient who has, given us consent to record a small interview. So Waleed, please, can you please ask the patient?
जब आप आई थी पहले उस टाइम क्या तकलीफ होती थी? क्या तकलीफ होती थी?
सबसे पहले आई थी मुझे हार्ट अटैक हुआ।
ठीक है, खुद उस वक्त तकलीफ क्या हुई थी? दर्द हुई थी? क्या हुआ था?
दर्द हुआ था ये इस चेस्ट में।
ठीक है।
और मैं इमरजेंसी में आई थी, वहाँ से मुझे इधर भेजा था।
उसके बाद फिर आपकी एंजियोग्राफी की थी हमने, एंजियोग्राफी में हमने बताया था कि आपका ऑपरेशन
उसमें नहीं, उस वक्त नहीं की थी। उसके बाद दूसरी दफ़ा की।
दूसरी दफ़ा एंजियोग्राफी की थी। ठीक है। उसके बाद फिर आपको बार बार ये तकलीफ हो रही थी?
बार बार हो रही थी।
उसके बाद आप कितनी दफ़ा दाखिल हुई हैं दर्द के साथ?
मैं कोई 6 दफ़ा, 6-7
दफ़ा। फिर आपके
दफ़ा
बड़े टेस्ट वगैरह भी कराए, ऑपरेशन डॉक्टर को भी दिखाया? ठीक है, लेकिन उन्होंने पहले कहा कि ऑपरेशन करना है, बाद में उन्होंने कहा कि ऑपरेशन नहीं कर सकते क्योंकि
पहले मैंने कहा था कि ऑपरेशन नहीं कराना, लेकिन जब ज़्यादा तकलीफ हुई थी तो मैंने कहा था चलो करा लेते हैं। फिर इन्होंने आगे पीछे सब कुछ किया है, आज तक किए, लेकिन फिर डॉक्टर कहते हैं कि आपकी एज नहीं है।
ठीक है,
ये सर्वाइव नहीं कर सकते।
ठीक हो गया। उसके बाद मुझे बताएं कि अभी दोबारा क्या मसला हुआ है जिसकी वजह से दोबारा आए? अभी दोबारा
ये लगातार डेली हो रहा था दर्द, हर रोज।
तो ये दर्द बैठे बैठे होता था या चलने से होता था?
बैठे बैठे, चल तो मैं सकती ही नहीं थी और न चलती थी।
ठीक है,
बैठे बैठे।
ठीक है। अभी कल हमने जब आपका ये प्रोसीजर किया, टांग से किया, उसके बाद अभी कैसा महसूस कर रहे हैं?
अभी तो नहीं दर्द हुआ।
ठीक है। अभी कल पूरा दिन दबाव वगैरह जिस तरह पहले
नहीं,
महसूस
कल
था?
नहीं हुआ, आज भी नहीं हुआ।
ठीक है। उस समय कोई तकलीफ वगैरह कोई इस तरह का महसूस नहीं?
अभी तो नहीं हुई।
ठीक हो गया। ठीक है। So this is all. So at the end, the take-home message is there's always some silver lining and there's always some light at the end of the tunnel. And the pot puff technique that we usually do, sorry I could not show the slide of that. We always, when we do a pot, we do a pot puff technique to see any downstream streaming of the dye. So it is sometimes called a poor man IVAS, and in this case it came out negative, and when we did that IVAS, the stent was well opposed. So it can be used as an alternative when the facility of IVAS is not available. So the take-home message from this is this. So I thank you all to present the panelists, and thank you very much.